Hello all, welcome to the new episode of Vertical Integration. So today we have got a very interesting topic. I think it's a very relevant topic. At any time of your season, it is very relevant to discuss regarding pneumonia. So we have an expert panel here. To my left, we have Dr. Nandita, who is from the Department of Anatomy, and we have Shruti, who is from the Department of Pathology, and Dr. Divya from the Department of Microbiology, and Dr. Anoop from the Department of General Medicine. So we have an expert panel here. So as the usual pattern, we have some preset questions. So we'll start discussing that. I hope at the end of the session we'll be covering in and out regarding pneumonia. So over to Nandita. Can you just start off with the first question? Can you just describe the anatomical structures of the respiratory system that contribute to the body's natural defense against the inhaled pathogens? And how does these structures get compromised in individual with higher risk of developing pneumonia? Please.
Yes, sir. So in lungs, there are many anatomical barriers.
Okay.
Among them, the respiratory epithelium serves as a major anatomical barrier. The primary defense which is put forward by the respiratory epithelium is called as mucociliary clearance. So in mucociliary clearance, we know that the tracheobronchial tree is lined by ciliated epithelium, and that is covered by an airway surface layer. So this layer consists of two components, a mucus component which is a viscous substance, and it is produced by the goblet cells which is in the respiratory epithelium. So they form a blanket over the cilia, and that helps in trapping the inhaled particles or inhaled pathogens. This mucus is also contributed partly by the mucus glands in the submucosa. The next component of this airway cellular layer is airway surface layer is called as periciliary layer. It is a low viscous fluid, and it is secreted by the serous glands in the submucosa. So they lubricate the cilia and increases their motility and thereby the ciliary beating. So these trap particles, they have to be transported out of the respiratory system. For that, our respiratory system has a mechanism called as mucociliary escalator. So in this, the cilia, so each of these cells, the ciliated cells have 200 cilia per cell. So the cilia, they beat in a synchronous manner upwards, and that is how the trap particles are moved upward, and it is disposed from the body.
Okay.
Apart from the ciliated and goblet cells, we have other kind of cells called as stem cells. So they have high mitotic potential, and they have the ability to differentiate into ciliated columnar cells and goblet cells. So in case of any injury, the cells can be replaced. And then other type of cell is called as sclera cells. So these are non-ciliated cells, and they produce surface active agents which is similar to surfactant, and also antimicrobial peptides and cytokines. So they also have bactericidal actions. So these are the immune defense mechanism in the ciliated airways.
Okay.
In the non-ciliated airway, that is the alveoli, there are only two type of cells. One is the type 1 alveolar cell, that contributes about 97% of the cells in the alveoli. So these cells, apart from maintaining the blood gas barrier, it also has phagocytic action. So its cytoplasm has lots of pinocytic vesicles, so it has phagocytic property, and it also absorbs the remnant surfactant which is present.
Okay.
And there is a type 2 alveolar cell called as pneumocytes that secretes the surfactant, and so they help in reducing the surface tension and prevents the collapse of alveoli. Apart from that, it can also differentiate into type 1 alveolar cell. So whenever there is an epithelium, there is always a connective tissue supporting it. So the connective tissue here is called as lamina propria. In the lamina propria, we have lymphoid tissue aggregates. So they are responsible for local immunological reactions against the pathogens. So what happens in old age, this ciliary beating, the motility decreases, and also the ability of the pneumocytes type 2 to turn into type 1 decreases. So that is it.
So that is the age-related differences that we have seen. And in any change in the infants, how long it will take to develop? In children, it will take a longer time, or at birth itself these cells will be developed?
So pneumocytes will take some time to develop.
Okay, fine. Thank you, Dr. Nandita. Starting off with the first question from pathology. Shruti, can you just describe the histological changes that occur in the lung parenchyma? So when we hear regarding congestion, red hepatization, grey hepatization, can you just tell regarding the different stages of lobar pneumonia?
So basically, pneumonia presents in two ways. That is, one is bronchopneumonia and one is lobar pneumonia. Telling in detail about lobar pneumonia, we have to see, pathologically we see gross specimen and microscopy. So I'll be discussing it in two parts, gross and microscopy. So there are 4 stages for lobar pneumonia, that is congestion, red hepatization, grey hepatization and the resolution phase. So in congestion phase, that is the first phase, what happens is lungs is like a sponge. So what happens when you put the sponge in water, it absorbs water and becomes heavy. Similarly, lungs also become boggy, heavy and reddish in color in the first phase of congestion. That happens in the first 2 days after infection. And on microscopy, what we see is the vessels get engorged, the alveolar spaces get filled with edematous fluid, there are neutrophils coming in place and there will be bacteria seen. So that is the first phase. Then comes red hepatization. Hepatization means liver-like.
Okay.
So on gross, what we see is the lungs become red, like very firm, like liver-like consistency. And on microscopy, we see a lot of exudates, plenty of neutrophils, red blood cells, and all coming into place. That is exudation within the alveolar spaces. Now, grey hepatization happens between 4 to 8 days. That is, the red cells start getting degenerated, destructed. So what happens is the lung color changes from red to greyish in tinge. The exudate will be present even in that phase, but the RBCs start getting degenerated. And grossly, what we see is, again, the lung is firm, hepatized or liver-like in consistency and greyish in color. Now the last phase is resolution, which happens after 8th or 9th day. So what happens is, whatever fluid, the fibrinous suppurative material inside the alveolus, it starts getting digested by the enzymes. So it becomes a semi-fluid granular material within the alveolar spaces. And what we see on microscopy is a lot of macrophages in action. The neutrophils will reduce in number, and the exudate will become less, and fibrous activity becomes more. Grossly, there won't be much of a change. It will start becoming normal.
No. Okay, fine. Thank you. Over to ma'am. Dr. Divya, can you list the common bacterial pathogens responsible for the community acquired pneumonia and hospital acquired pneumonia? How does the patient's underlying health status influence the causative organism?
So, firstly, pneumonia, it is the inflammation of the lung. So, from the epidemiological point of view, we can classify pneumonia into community-acquired pneumonia and healthcare-associated pneumonia. So, community-acquired pneumonia is basically the patient is getting the infection from the community as well as within 48 hours of admission in the hospital. And healthcare-associated can again be classified into 2, hospital-acquired and ventilator-associated pneumonia. Hospital-acquired means in non-ventilated patients, they are getting infection after 48 hours of admission, and ventilator-associated pneumonia means they are getting 48 hours after mechanical ventilation or endotracheal intubation with a new or progressive infiltrates or signs and symptoms of systemic infection, or they will be having a worsening of oxygen. So that is the ventilator associated. So coming to the causative pathogens, community acquired pneumonia causative pathogens can again be classified into typical or lobar pneumonia causative pathogen and atypical. So in typical, the most common is the Streptococcus pneumoniae. Then comes the Haemophilus influenzae, Staph aureus can cause, and other gram-negative bacilli like E. coli, Klebsiella, Pseudomonas can be causative agents, and also rarely some pathogen like Burkholderia pseudomallei can also be a causative agent of community-acquired pneumonia. In typical pneumonia, bacterial pneumonia, atypical, 3 pathogens are most commonly seen, that is the Mycoplasma pneumoniae, the Chlamydia pneumoniae, sometimes Chlamydia psittaceae can also cause, and the Legionella pneumophila. So coming to the healthcare associated, it is mainly MDR pathogens are causing, that is the Pseudomonas, Klebsiella pneumonia, E. coli, any MDR pathogen, Acinetobacter species can cause pneumonia. Now, how the patient's health status is affected by these causative agents, depending upon the predisposing factor, the causative agents can also differ. So, extremes of age, like infants, and old age, like more than 65 years, it is more common in Streptococcus pneumoniae. Asplenia, splenectomized patients, hemoglobinopathies, they are also more commonly affected by Streptococcus pneumoniae. But in COPD patients, smoking history, chronic alcoholism, Haemophilus influenzae can be seen. And also diabetes. Diabetes is the most common cause of Burkholderia pseudomallei. And the recent hospital administration, antibiotic exposure, recent invasive procedures are the common cause of hospital-acquired pneumonia.
I totally missed asking you viral pneumonias. So that's
Okay.
again one of the most common. I have missed in the question. So
Okay.
that's again one of the etiological factor which
Viral pneumonia is seen in, among typical pneumonia. Respiratory syncytial viruses are there, adenovirus, even coronavirus can be seen as a community acquired pneumonia. The MERS, all those can
All
be
those
seen.
they can-
Even fungi can also cause certain community acquired pneumonia.
Okay, fine. Thank you. Thank you, Doctor. Yeah. And Dr. Anu, can you just enumerate the clinical features of a community acquired pneumonia and how the symptoms can vary depending on the causatic organism? Just a brief overview.
Sir, just taking over from what Madam has said, I'm actually putting my reference from Fishman and Murray, IDSA,
Okay.
and American Thoracic Society.
Okay.
So, as Madam said, generally for all infections, we consider immunosuppressive states like diabetes, uncontrolled diabetes, patients who are taking steroids, patients who are having autoimmune diseases, cancer, chemotherapy, all the regular things, CLD, CKD, all those things. But Harrison, the latest edition of Harrison has described a table in which there is a specific set of people who will get complicated pneumonia from the communicative acquired pneumonia. It does not include all this. It is patients who have received antibiotic therapy in the last 90 days, or patients who have been hospitalized in the last 90 days, non-ambulatory patients, CKD patients on dialysis, okay, so, and patients with structural lung disease like COPD and bronchiectasis. So just rephrasing what Madam said, community acquired pneumonia, the commonest organism, of course, it is Streptococcus pneumoniae and Haemophilus influenzae. But when you come to these particular set of people, they have more predilection to get something called a complicated pneumonia. So complicated pneumonia, the organisms that we usually, the most common organisms are first your dreaded organism MRSA, methicillin-resistant Staph aureus. Then you have Klebsiella and of course Pseudomonas. And in a quaternary center like Amrita, we see even, in hospital-acquired pneumonia, especially when you talk about it, we have CRAB, that is carbapenem-resistant Acinetobacter baumannii, but I don't think that will be there in the other hospitals. It will be, these are severely resistant strains. So whenever we defined clinically regarding the severity, the curve 65 or the typical thing that we say about pneumonia, that is cough with rusty sputum, high spiking fever, confusion, bun more than, all that actually refers to lobar pneumonia, which it will be having a exudative solidification of the lung parenchyma, and by definition it is from the respiratory bronchiole to the alveoli. Now, just adding on to what pathology, what Madam had said, initially the theory was that we need to aspirate, the lung is a sterile area, and we need to aspirate a lot of material to actually cause pneumonia. But that concept has been changed according to the latest guidelines and the latest literature, if you refer to. Lung is not a sterile area. The BAL examination of normal lung actually shows just a very fine equilibrium of balance between a lot of organisms that is maintained. Now what happens is, when there is, if you look at the lung structure, you have the capillary endothelium and the alveolar epithelium. So there is an injury that is initially happening, which triggers an inflammatory response. It leads to something which is called an alveolo-capillary leak. Okay, so just like how we would have observed small children when they sleep, they have a crusting of saliva. This inflammatory change causes this alveolar cap, and that forms an exudative membrane around the alveoli without infiltrating into the alveoli. And also you have this inflammatory exudate inside the alveoli, which is not. The peculiarity of this alveolo-capillary membrane is that it is which gives the solid definition to the lung, which makes it looks like the liver or gives the consistency of the liver. It allows carbon dioxide to pass through. It does not allow oxygen to pass through. So initially, what you are seeing in the lobar pneumonia, as I say, fever, all that, the patient will be having a type 1 respiratory failure because it is not allowing the oxygen to pass through. Whenever we have a difficulty in getting oxygen, we will actually increase our respiratory rate. So initial picture will be a type 1 respiratory failure followed by type 1 respiratory failure with respiratory alkalosis. So now I am talking about a clinical situation where the patient has only lobar pneumonia. Okay, and when you come to interstitial pneumonias, the ones which gives rise to the bronchopneumonia interstitial pattern, among the viruses, COVID virus and influenza, and we have the atypical organisms, that is mycoplasma. So if you take the category, the most common, Streptococcus pneumoniae, second is Haemophilus influenzae. If you take all pneumonias together, the third rank is obtained by mycoplasma. last ranked by chlamydia. And Legionella pneumonia has a particularity. Even though it is classified as an atypical organism, it has the propensity to develop both interstitial pneumonia as well as lobar pneumonia. And if you look at the criteria, there are certain specific clinical characteristics like transaminitis, diarrhea, hyponatremia. These manifestations are said to be classical of Legionella pneumonia. Now, when you take Klebsiella pneumonia, textbooks describe a typical something called a bulging fissure sign. If you have an upper lobe pneumonia with a bulging fissure sign, it is usually supposed to be Klebsiella. The kind of all the categories of patients that we told about, the first organism that is most likely to be there is Streptococcus pneumoniae. Organism associated with atherosclerosis is considered to be chlamydia. So in this, I'd just like to add on that curb 65, the bedside scoring that we immediately use in the ER as well as in other places. So confusion, urea more than 20. So there you're talking about blood urea nitrogen. Blood urea nitrogen more than 20, which corresponds to urea more than 40, respiratory rate more than 30, BP less than 90, 60, and age more than 50, 65. So to admit the patients, we use this criteria at the bedside. The more specific criteria is pneumonia severity index, but that has around 20 variables. So this is, I think, for bedside assessment. So if you have a score of 0, OP, 1 and 2 IP, 3 ICU. That is what we generally follow here.
Thank you. So in a nutshell, we can just say that the clinical features, the classical one starting with a fever, cough, breathlessness.
The 6 cardinal symptoms that I described are cough, pleuritic chest pain, dyspnea, hemoptysis, and cough, hemoptysis, dyspnea, and your pleuritic chest pain, dyspnea, and sometimes associated cough and expectoration is also defined as one of the other criteria. So these are the 6 cardinal symptoms that are mentioned.
Thank you. Coming back to Dr. Nandita, can you explain a little bit regarding the blood supply of the lung and how it relate to the potential of spread of infection from the lung to the other part of the body?
Yes, sir. So in lung there are 2 functionally distinct circulation, one which is involving the pulmonary vessels that brings deoxygenated blood to the lung, and the one which is involving the bronchial vessels that brings nutrition or the oxygenated blood to the lung. So the pulmonary artery, it arises from the pulmonary trunk, so there is a right and left pulmonary artery. So these pulmonary artery, they enter the lung through the hilum and they follow the division of the tertiary bronchi, and it supplies a corresponding bronchopulmonary segment, and finally they undergo division, and by the time it reaches the terminal and the respiratory bronchiole, they become arterioles. And again they break up into capillary plexus near the alveolar surface, so that is where the oxygenation takes place, and the venous end of this capillary is joined to form intersegmental veins, and the intersegmental veins of each lung join to form the pulmonary veins. So there is a superior and an inferior pulmonary vein, and these pulmonary veins, they go to the left atrium, to the left ventricle, to the aorta, and through the aorta to the whole body. And the bronchial artery is arising from the thoracic aorta. So on the right side there is one bronchial artery, on the left side there are 2. And this bronchial artery, it follows the division of the bronchial tree, and it supplies blood up to the terminal bronchiole. That is, it divides into 2 sets of branches, tubal branches and septal branches. Tubal branches supplies the terminal bronchioles, and the septal branches, it is present in the interlobular septa, and it supplies the pulmonary pleura, that is the visceral pleura. So this branch of the bronchial artery, that is the tubal branches, they are drained into the pulmonary veins because they anastomose with the branches of the pulmonary artery, and finally they drain into the pulmonary veins. But the septal branches, they are drained by the bronchial veins. So this the oxygenated blood which is brought about by the bronchial veins drains into bronchial artery, drains into bronchial veins and pulmonary veins. So the bronchial vein, the right bronchial vein finally drains into arch of ascyagus, and the left, it drains into accessory hemiascyagus. So
that is how the spread of infection.
Yes, sir.
Okay, thank you, Doctor. Over to Dr. Sudhi. Can you just compare and contrast the pathological features of lobar? I think we have touched up, but a little bit about lobar pneumonia, bronchopneumonia, and interstitial lung disease. The 3 to differentiate.
So lobar pneumonia I've already discussed before. That is 4 stages: the congestion, red hepatization, grey hepatization, and resolution. And I have explained the gross with it. So in bronchopneumonia, the major difference between lobar and bronchopneumonia is that in bronchopneumonia, grossly we see patchy areas of consolidation, wherein lobar pneumonia, either the entire lobe or a large part of one single lobe is affected. That is how we differentiate it grossly. But most of the time there is an overlap between the features. And in bronchopneumonia, microscopically, what we see is dense suppurative inflammatory exudate within the bronchi, bronchiole, and the adjacent alveolar spaces. That is between the lobar pneumonia and bronchopneumonia. Interstitial lung disease, it's a little different from the both of them because it's more of chronic inflammation seen in it. Where in bronchopneumonia and lobar pneumonia, it is more of acute suppurative inflammation what we are seeing. In interstitial lung disease, what we see grossly is the lung becomes shrunken and it has a cobblestone-like appearance on the external surface because of retraction of scar tissue formation. And on cut surface, we see whitish, fibrotic, hardened tissue of the lung. On microscopy, it can be early or late phase. In early phase, it is more cellular. It is more of fibroblast what we see on microscopy. And in later phase, we see more of fibrosis and very less inflammatory, sparse inflammation, mostly composed of lymphocytes and very sparse amount of neutrophils, eosinophils and mast cells. That is the difference.
Thank you. Thank you. Over to ma'am. Can you, ma'am, we say regarding strep pneumonia. Can you just describe the virulence factors and how they contribute to the development of pneumonia, specifically for strep pneumonia?
Okay. First of all, Streptococcus pneumonia, it is a gram-positive cocci, which is seen as diplococci in the gram state.
Okay.
So we can say it as gram-positive diplococci, and it has an alpha hemolysis in the blood agar plate. So these organisms, they are seen as colonizers in the upper respiratory tract infection, and these also it has a various number of virulence factor, lot of virulence factor, and these virulence factors will contribute into the in the pathogenesis of the disease. So the first and the principal virulence factor is the capsule polysaccharide, and this capsular polysaccharide will prevent the phagocytosis of this organism. Other than the capsule polysaccharide part, it also has various proteins, streptococcal proteins, which play a major role in the virulence. And one is an IgA1 protease, which interferes with the host defense mechanism at the mucosal surface. The one is that. Then also we have streptococcal or pneumococcal surface proteins. So these pneumococcal surface protein, it will prevent the complement activation. And also this produce pneumolysins. Pneumolysins are membrane damaging toxins which prevent the neutrophil chemotaxis, as well as it prevents the phagocytosis also. Even there is another amidase enzyme which is called as autolysin, which will self-destruct the organism itself. It will destruct the peptidoglycan layer, and what happens is that it releases the bacterial component and it results in a cytokine cascade. It will activate the inflammatory system. And also it has choline binding receptor, neuraminidase, and there are some pili which helps these organisms to adhere to the cell surface and play a major role in the inflammation. So all these virulence factors together contribute to the pneumonia or pathogenesis of pneumonia. And when the host defense mechanism is when it is immunosuppressed or it is less, or the host immune cells cannot eliminate these pathogen or clear out this pathogen, it results in pneumonia.
Thank you. Over to Dr. Anup. Can you just describe the physical findings, examination clinical findings of a pneumonia, and specifically percussion, auscultation, those findings?
So just a continuation of from where I had stopped. So there is an exudative solidification. So we have
clinical features.
Features. Clinical features. So essentially, this clinical features are
examination findings is what I
are
asked.
Because I'll just enumerate the findings first. The patient will have a peculiar characteristic of breath sound, which is they have a bronchial breath sound.
Okay.
Their VF and VR, vocal fremitus and vocal resonance, will be increased. So we have learned in physics that solids conduct sound vibrations more than liquid, more than air. So the principle is the same. As Madam said, the lung is becoming partly from solid and partly this thing to a complete solid structure. So VF-VR is increased, and bronchophony, egophony, these are all different, additional sounds that can be heard along with the bronchial breath sounds. And as far as the percussion note is concerned, the classically described percussion note is something known as a woody dull percussion note, and that is again because of the exudative solidification of the lung parenchyma as far as physical findings. And the other findings when we assess the patient regarding, first it starts from the history. We have to look for the specific category of patients and ask for, and just to add on to what Madam had said, healthcare associated pneumonia. We have only hospital acquired, ventilator associated and community acquired. Healthcare associated pneumonia was usually a term given to patients who are getting specific group of organisms associated with nursing care, elderly people. But that term is now taken off because they have found that the organisms that they isolated from the BAL is almost same as that the organism which we get from the community. So take a proper history and the catastrophic presentation, severe presentation, high spiking fever, confusion. You can also have SIADH causing hyponatremia. Elderly patients, this is one thing that we usually find that they need not have high spiking fevers. They usually present with a febrile delirium more than with high spiking fevers. And of course, the other characteristics. Now, I had told about the pneumonia severity index. It has around 20 variables. But in brief, if we tell about it, there are two major criteria out of which one should be there, and many minor criterion out of which, so there should be either one major or three minor criterion. The major criterion said to be assessing the severity to admit the patient in the ICUs. One is requirement of mechanical invasive ventilation. One is, the second major criterion is hypotension that requires inotropes. Minor criterion also there is hypotension, but it is not inotropic requirement, but which can be corrected by fluid resuscitation. Then other factors are there. Confusion is there. Then you have leukopenia is there. Then uremia is there. Then respiratory rate more than 30 is there. And these are some of the criteria. So if you, out of the minor criteria, if you have three or one major criterion, you have to admit the patient in ICU. Otherwise, we are depending on OP or IP care depending upon the clinical condition of the patient.
Okay. So the major clinical examination findings that we will have tachypnea, hypoxia, respiratory failure, accessory muscle usage will be seen. Then you said regarding the auscultatory findings, regarding vocal fremitus, vocal resonance, then the percussion note, dull percussion note on auscultation, and if they have any complication, if there is an associated pleural effusion, pneumonia effusion, will be getting the.
You'll get an additional. That is another point that I missed out, sir. When you mentioned, I just got reminded of it. You can have something known as pneumonic effusion, which is usually there. So Light's criterion actually helps to distinguish only between.
That we can discuss in pleural effusion.
Yes, pleural effusion. Yes,
because a lot of confusion we will have when we are covering a lot of stuff. So we'll just restrict to the clinical
but you can
examination
have
findings.
Pneumonic effusion or parapneumonic effusion or empyema.
It's basically an exudative effusion that you are expecting.
All three are exudative effusions.
Yes. Coming to back to ma'am, can you describe the innervation of the diaphragm and how it can be affected by the inflammation of the pleura, which can be a complication of pneumonia? We'll see a lot of patients with pleuritic chest pain. So can you just elaborate on that?
Yes, sir. So diaphragm is a muscular partition between the thorax and the abdomen. It has a central tendon and two domes, that is the right and the left dome. And the thoracic surface of the diaphragm will be covered by a diaphragmatic pleura. So the diaphragm has motor and sensory supply. The motor supply is derived from the phrenic nerve. So there is a right and left phrenic nerve, and they take origin from the cervical plexus, the ventral rami of C3, C4 and C5, and they have a cervical thoracic course, and the right phrenic nerve passes through the opening of IVC in the diaphragm, and the left phrenic nerve, it pierces the left cupola of the diaphragm, and they ramify beneath the diaphragm or within the substance of the diaphragm, and they give motor supply to the diaphragm from the abdominal surface. Now the sensory supply is, the peripheral part will receive the sensory supply from the lower 6 intercostal nerves, and the central part will receive the sensory supply from phrenic nerve. So the corresponding pleura will also receive the nerve supply as such, like the central part of the diaphragmatic pleura from the phrenic nerve and the peripheral part from the intercostal nerves. So when there is pleurisy or inflammation of pleura, if the central part is affected, then the pain will be radiated to the tip of the shoulder because of the same dermatome, that is C3, C4. And if the peripheral part is affected, that is the lower 6 intercostal nerves, then the pain will be felt in the anterolateral abdomen because it has the same sensory supply.
Okay, thank you. Over to Shruti. Can you just tell me regarding the role of cavitation in lung pathology and how its presence can influence the diagnosis and management of pneumonia?
So cavity means a hollow space within the lung parenchyma. It is usually produced because of destruction of the lung parenchymal tissue by necrosis. So it's usually seen in severe forms of pneumonia. Few of the example organisms which can cause cavitation along with pneumonia are one is Klebsiella, staph, strep, and Haemophilus influenzae are few of the examples. So these patients who have cavity along with pneumonia, they have a higher chance of developing empyema, bronchopleural fistulas, or they can form abscesses.
Okay.
So the management varies for these patients. Along with pneumonia, they have to undergo some surgical treatment or drainage if required. And then the investigations usually sent for such patients are first is sputum examination for isolating the organism and treating accordingly. And other is bronchoalveolar lavage is what we get. And even after the empirical treatment, if it does not resolve, we also get lung biopsies very rarely, just to rule out malignancy if there is any chance, which is hiding under the pneumonia.
Thank you. Thank you. Over to ma'am again. Ma'am, can you just explain the role of atypical pathogen? We have already discussed, but just to have an overview of again, Mycoplasma pneumonia and Chlamydia pneumonia in causing pneumonia, and how their diagnosis differ from bacterial pneumonia.
Okay. So first about the role of atypical pneumonia. So I said most commonly three organisms, atypical organisms are seen, that is Mycoplasma pneumonia, the Chlamydia, Pneumonia encephalitis, as well as Legionella pneumophila. So they are acquired from various sources. The first, if I talk about Mycoplasma pneumonia, it is mainly from the respiratory droplet. Transmission is mainly from the respiratory droplet during an expectoration or cough. So these organisms are mainly transmitted or seen in patients associated with close living conditions, like when you have a military barrack or a school or a summer camp. In those areas, these are most commonly seen, and there is person-to-person spread. So in coming to Chlamydia pneumonia, there also the transmission is by inhalation and by contaminated aerosol droplets only, and there is person-to-person spread is seen. And in case of Chlamydia psittaci, that is zoonotic. It is mainly by direct infection with the birds, infected birds, or through the inhalation of the avian nasal discharge or avian feces. That can happen when the patient or the person is taking care of the birds. Then the third is Legionella pneumophila. They are mostly seen in aquatic water reservoirs. It is seen in natural reservoirs, but most commonly the infection is caused when we are having artificial reservoirs like coolers, humidifiers, air conditioning systems, also these whirlpools, fountains, spas, even the shower. So all these can cause aerosolation and cause disease. And even in the hospital setup, the nosocomial pneumonia can be caused when the hospital water system is affected. So that is the role of most common atypical pathogens. So how the diagnosis is, the lab diagnosis of community acquired pneumonia and atypical pneumonia are different. So first I will start with the community acquired bacterial pneumonia. So the most important thing is the specimen. So we have different respiratory specimens like sputum, bronchoalveolar lavage, protected specimen brushing, endotracheal aspirate. So depending upon the disease, we are sending the specimen. But in case of community acquired pneumonia, sputum is the most common specimen, and it is a non-invasive specimen. It is easily obtained. So another important point regarding the specimen is that when you are sending a specimen for lab diagnosis, always collect the specimen before antibiotic, prior to antibiotic is given. So you send the specimen, first we do a gram staining. So the gram staining, the importance in community acquired pneumonia is the quality of the sputum. So first you will determine the quality of the sputum, and second is you can identify the pathogen. You can have a presumptive identification of the pathogen based on the morphology in the gram stain. So how will you determine quality of the sputum? Mainly we look for the Bartlett scoring. Or in short, we can say that if the inflammatory cells are more, that inflammatory cells are more than 25 in the lobar field and the epithelial cells are less than 10 in the lobar field, you can say that it is a good quality sputum, and we can get a good yield of the pathogen from that sputum, and it is ideal for culture. So if it is not so, then you have to reject the sputum because it contains more of saliva. Salivary contamination is there, and you will only get the commensals. The pathogen will be suppressed even if the saliva contains little bit of the pathogen. So if it is a good quality sputum, then you can take it for culture. So when you're doing a culture, the most common or the most important three artificial media that we use are the blood agar, the chocolate agar, and the Mekong agar. So what is the importance of these media? So blood agar will allow the growth of these fastidious gram-positive cocci like Streptococcus pneumoniae, And also they will help in identifying the colony morphology and the hemolysis. And in the blood agar plate, if you're using a disc called Optochin disc, which is a 5 microgram disc, you can presumptively identify Streptococcus pneumoniae from the viridient streptococci, which are also the commensals of the upper respiratory tract. That is one of the point. The second is chocolate agar. Why we are using? So it will help in the recovery of Haemophilus influenzae, and it can be supported by a bacitracin 10 units disc. Bacitracin will be resistant to the colonies of Haemophilus influenzae. The third is McConkie agar, where when we are suspecting the gram-negative bacilli, you will get a presumptive identification whether it is a lactose fermenting or non-lactose fermenting. Based on that, you can have an identification of the organism. In addition to the gram stain and culture, we have also other tests like supportive tests like urinary streptococcal antigen test is there, which gives a presumptive identification of Streptococcus pneumoniae, the most important pathogen, within 3 days from the 3 days of onset of symptoms. And also blood culture can be sent in high risk patients. So these are the points in favor of bacterial pneumonia. But in case of atypical pneumonia, this gram stain and culture does not yield much. It is not good, because when you do a gram stain in case of atypical pneumonia, you will be seeing lot of inflammatory cells, but you won't be seeing any organism. Culture can be done, but it requires complex medias. Example, in case of Mycoplasma pneumonia, you require pneumonia, standard Mycoplasma pneumonia medium like PPLO agar and broth. Chlamydia requires cell lines. Legionella requires buffered charcoal yeast extract agar. These are the complex medias, and it takes some time to grow, which is not very useful in patients. So now you have to go for serology and molecular methods. So in serology, better than a single titer, a 4-fold rise in titer is always considered as significant, and various molecular methods are available like multiplex PCR. In case of Legionella pneumophila, you have urinary antigen test with enzyme immunoassay, which gives a rapid identification, which is fast, and even with the prior antibiotic administration, it can give positive results. And also there is a syndromic testing called as BioFire film array panel, which has a pneumonia panel which cover both typical as well as atypical pathogen, which is very useful in patients with community acquired pneumonia. And even viral and fungal, viral and antimicrobial resistance can be detected in the pneumonia panel.
Thank you.
It gives in 1 hour. It gives the result in 1 hour. BioFire pneumonia panel, we get the result in 1 hour. It covers almost 34 pathogens.
34 pathogens. That's ideally as early as possible we should be able to do before antibiotic administration. It's a PCR based assay. Okay. Over to Anup again. Can you just specifically discuss the role of chest X-ray in the diagnosis of pneumonia, and what are the limitations of an X-ray, and when you need a CT in case of a pneumonia?
Sir, as I had earlier told, the basic 2 types of pneumonia, that is the primary role of the X-ray. When you get a lobar pattern, and in specific cases, like I told you in Klebsiella, if you have a bulging fissures and usually an upper lobe, this thing X-ray can be very useful. So primarily it is to distinguish between the lobar and the role of the CT is actually ultrasound is actually gaining quite the focus. Point of care ultrasound is gaining a lot of this thing, because it can be done immediately at the ER. There is a specific signs described like shred sign for consolidation, and the air bronchograms, that is what old clinicians used to say regarding the X-ray. It will appear black in color in the X-ray, but in the ultrasound it will appear white in color. And dynamic air bronchograms, especially when you do the ultrasound, you can see that the air bronchograms are increasing and decreasing in size with respect to breathing. Those are them. Now coming to CT, when it is actually required is for analysis of our treatment. Most of the times, even though if it's a topic for another day, whenever patient is having lobar pneumonia, we start with appropriate antibiotics, which I'll be telling in the next this thing. We have to, even after 4 or 5 days of treatment, if the patient is continuing to have fever, we are not hitting the right this thing, or there can be multi-drug resistant organism. One very important possibility is that the patient might be going in for empyema. Or other things. So, in that case, when the patient is not improving, we might require a CT to look if the patient is having empyema. And then another thing is the treatment. Actually, many of in the treatment guidelines, fluoroquinolones like levofloxacin have been mentioned, and that is also as a part of treatment in the tuberculosis also. So as I told you, I'm referring to the American Thoracic Society guideline. But in a place like India, when we practice, because tuberculosis also starts as a pneumonia, and we shouldn't miss, the treatment with levofloxacin should not be done as much. So the role of chest X-ray is only as much as.
So the chest X-ray basically we have to take for any pneumonia that is suspected. That's a basic for all the pneumonias that we suspect to basically look for a lobar, broncho, or an interstitial pneumonia. We can get a basic differentiation, and also we can look in for any of the like a pleural effusion additionally, air bronchogram.
Yes.
It's a cavitatory pneumonia. It's an upper lobe pneumonia. We'll think of like Klebsiella, like tuberculosis. If it's a middle lobe, we have a lot of differential diagnosis. And with a bilateral, we'll commonly think of an interstitial pneumonia, viral being one of the most common, and an atypical pathogen also.
And
if a non-resolving pneumonia, as you said, we will think of a CT. Routinely, we don't prefer to take a CT maybe the initial first 3 to 4 days if the pneumonia is not resolving, or if the patient has gone into any other complications, like as you said, we'll go ahead with the CT. Thank you.
Sir, one more point I would like to add, especially this is just a theoretical point. MRSA has been described to have multiple small pneumatocytes. So those kind of specific things are there.
Okay, fine, thank you. And again, related to X-ray, can you just, location of different lung lobe, can you just correlate superior, inferior, middle? When you look at an X-ray, how will you be able to differentiate these things? Can you just elaborate on it?
So this lung field, it appears black because of the presence of air. And what can be made out in the X-ray is one, the bronchial and the pulmonary vessels. They appear as green linear markings, and then we can make out the fissure. So in the right lung there is an oblique and a horizontal fissure. Oblique fissure being the major fissure, it separates the upper and the lower lobe. Oblique fissure is well visualized in a lateral view more than the PA. And in the left lung there is an oblique fissure that separates the upper and lower lobe. Okay. So for radiological purposes, the lungs is divided into 3 zones. The upper zone, which is extending from the apex of the lungs to the line drawn along the anterior border of the second costal cartilage. Okay. The middle zone, which is extending from the upper limit of from the lower limit of the upper zone to the line drawn along the anterior end of the fourth costal cartilage. So that contains the hilum. That area comprises the hilum of the lung, and the lower zone, which extends from the lower limit of the mid zone to the base of the lung.
Okay.
So these are.
Thank you. Dr. Sudhi, we have discussed regarding a lot of pneumonia. What is the long-term complications, pulmonary complications that we need to arise following an episode of severe pneumonia? We said regarding cavitation. So similarly, what are the problems that we will anticipate?
So most of the complications have been already discussed.
Yes.
So just repeating few of them. One is pleural effusion, as he has already mentioned. One is empyema, and we can get cavitated lesions, bronchopleural fistulas. It can even spread systemically, causing infections like meningitis, endocarditis, septic arthritis, which are few of them.
Okay. Yeah. So just we are completing everything. So that's why. Ma'am, you discussed regarding gram staining. Can you just give a little bit elaboration regarding how does it to help in antibiotic selection? Once as a clinician, we have we are asking for a gram stain. So how does it help us for an antibiotic selection?
Okay. So first point here is a good quality sputum will give a good quality result. So if the gram stain or culture to be adequate or satisfactory, you have to give a good quality sputum. So, this AETCM guideline, as Sir said, for the mild cases, in the OP setting, the gram stain and culture are not recommended. Only in case of severe community-acquired pneumonia, if the patient is hospitalized for the previous 90 days or patient is having antibiotic therapy, or if they are treated for empirical MRSA or pseudomonas, or if the patient is ventilated, in such cases, you can send a gram stain and culture. So that is the importance of gram stain and culture. And how it is guiding the antibiotic therapy is that you will get, by a good quality, you will get the definitive pathogen. It helps in the antimicrobial, you can do an antimicrobial susceptibility testing. Then that will help in monitoring the treatment response. You can get the resistant pathogen, and from the gram stain you will get a rapid identification. Also you can know about whether it is an atypical pathogen. So if you suspect that it is having an atypical pathogen, you can send a serology If the patient's symptoms are suggestive of lower respiratory tract infection, you can send for a serology.
It's one of the simple tests which can be
Which
made
can be
effective if you are getting a good sputum.
Good sputum.
Thank you.
So, typical pathogen, madam,
Yes.
we commonly send, is it a serological test or rapid antigen test which is...
As of now, we have for atypical Legionella pneumophila urine test is available and Mycoplasma enzyme immunoassay is available.
This typical pneumonia panel that we usually send it is...
We don't have the BioFire pneumonia panel.
Okay.
We have BioFire only joint panel because virology has some other panels. So we are not going for the pneumonia panel. But if you have a pneumonia panel, you can get the result in one.
All the 34 as
pathogens can be obtained
including
in one hour.
fungal. Tuberculosis covers under that one, BioFire panel? No.
TB, no.
No.
TB, I don't think so.
Okay. Coming to the last, antibiotics. Pneumonia, community-acquired pneumonia. So, how will you plan your antibiotic strategy? We can just start off from curve 65.
Yes,
1, 2, and 3. You
Sir,
can
has just read my mind. I was just coming, just like how we described initially classifying patients. Score 0 is OP, 1 and 2 IP, 3 and above. So in OP patients without any expected complications, or patients without any comorbidities, the drug that is preferred is amoxicillin, 1 gram TDS. So in OPD without complications, it's or. So either amoxicillin 1 gram, or you can give a macrolide, azithromycin 500 OD. Due to some ECG changes which are described with 500 OD, the recommended dose is 500 OD for the first day, then 250 OD for the remaining 4 days, total 5 days. Clarithromycin we can give 500 BD, or we can give doxy 100 mg BD, that is for OPD. OPD patients with comorbidities, but that I'm not talking about the table described that patient can go into the other comorbidities like diabetes, metabolic syndrome, those kind of things, high risk patients. We usually give combination. We have to give either, when not amoxicillin alone, amoxicillin with clavulanic acid. That is, we have 1 gram as well as 625. 625 is what is described. That is amoxicillin with clavulanic acid, 625 TID plus azithromycin 500 OD. Or you can give it that along with clarithromycin 500 BD. Or we can give that along with, but both has to be given, doxycycline 100 BD. You can also give, the latest recommendations also say cefpodoxime or cefuroxime acetyl. The trade name available is Ceftum, that is one of the good molecules, 500 BD. Or cefpodoxime we can give along with the same combination, azithromycin, clarithromycin or doxycycline. So that is regarding the OPD. Now, IP patients who we are not expecting to go for a complicated pneumonia, we switch on the same thing to IV drugs. That is, this amoxicillin, we make it ampicillin with sulbactam, 1.5 or 3 grams Q6H we give. Along with that, we have to give azithromycin, a macrolide, or clarithromycin.
Basically for your typical coverages.
Yeah, that's right. And the same thing, OPD, we had said cefpodoxime, cefuroxime. The same thing, IV, beta-lactam, the cephalosporins. Ceftriaxone, the dose described is not the one we usually give 1 gram a day. It is 2 gram IV OD, that is said for pneumonia, plus the same combination. But always the combination has to be given. And for uncomplicated pneumonia, the third, this thing is levofloxacin monotherapy. There we do not have to give a combination. But if we are having a patients who are expected to go to a complicated pneumonia or a category of patients, then the preferred is again we can give ampicillin sulbactam with azithromycin, ampicillin or ceftriaxone with azithromycin, and there levofloxacin monotherapy is not advised. Instead of this azithromycin or this thing, we can give ampicillin sulbactam with levofloxacin, but it's always used as a combination thing. And as I had earlier mentioned, when the giving of doxy is not very preferred when you are actually admitted in the ICU, I mean admitted in the hospital. We prefer the combination with macrolide or with levofloxacin for complicated pneumonia patients. And for the specific group of organisms, that is, I told you one of the reasons why the patient is not improving is we are not targeting the right organisms, and in some places we can get the other group of organisms. So if you are suspecting a pseudomonal pneumonia, we can give coverage with piperacillin tazobactam, we can give coverage with imipenem, meropenem, ceftazidime avibactam, cefepime, all that can be given against pseudomonas. We can add vancomycin or linezolid if you are suspecting MRSA, and that's about it,
so
sir.
it's basically from the OPD to the ICU.
Yes.
So at the end, you want to give your MRSA coverage,
Yes.
and multi-drug resistant when you suspect.
Yes.
So thank you. So thank you all for that fruitful discussion. Once again, on behalf of Amrita School of Medicine, I thank each one of you for attending this session. Thank you.
Thank you so much, Srishant sir, for giving us an opportunity to discuss one of the most commonly encountered cases.
Thank you.